I would like to express or tell you about the experience of bloodless management in the Philippines, as we have done it several years ago. One is going to be taken into the history a little bit of this bloodless medicine and surgery in the Philippines. But as you would probably notice, this is something that is ongoing and will continue to be so. Patient bloodless management, as we all know, is an evidence-based multidisciplinary approach to the care of patients who might need transfusion. And the objective is really to reduce the need for allogeneic blood transfusions while ensuring that available blood is available to those who really need them. So in many ways, we are all, in a way, practicing patient blood management. But in the overall, the patient blood management allows one really to use blood in the most extreme of circumstances. So it's not unusual for a patient blood management program to say that we have reduced the need for blood transfusions, but blood transfusions were still given. In other words, patient blood management encompasses what we're doing now, but really, bloodless medicine and surgery absolutely will not use blood products or forms that is fitted towards the belief of Jehovah's Witnesses. So the pillars of patient blood management and bloodless medicine and surgery are really the same. There's no difference. Optimize hemoglobin hematocrit, and then you have erythropoietin, you have parenteral iron, then you have folic acid and all that stuff, vitamin B12. And so we notice here that when these things come into play, then really it's a good thing to have that. It takes time though. There is a limited time for this to respond. And we all know that. In other words, in some instances, this is not really something we can lean on. You do that in an elective case and you wait for 3 weeks before you can do whatever you like to the patient. Of course, minimizing blood loss is another one. And if you really look at minimizing blood loss, there are many ways of doing that, making sure that the patient is not on anticoagulant therapy, minimize blood draws, employ ANH, cell salvage, meticulous homeostasis, and can use tranexamic acid, a protein, and vasopressin. So all these things we use in a given patient during surgery and even in preparation after surgery. Optimize oxygen delivery. When one looks at optimization of oxygen delivery, it's just really maintaining the favorable balance. It's a question of supply being more than the demand. And of course, how do we do that? You can have hypothermia, you can have a lot of stuff, barbiturates, muscle paralysis, assisted ventilation. So when you look at that, then something is going to be really demanding in many ways, but you can do a lot of things to help out how to optimize oxygen delivery. The last one is what I really would like to highlight on. Early in the days of bloodless medicine and surgery, when we started to do that in sometime in 92, in 85 actually, we had not much information. So how do we go about convincing doctors to do surgery for Jehovah's Witnesses? How do we do that? It's kind of difficult, especially when you don't have the literature to back you up. So we still consider patient-centered care. We would like to treat them over hemoglobin number. And it's always have the guide course of action that hemoglobin may not be really the numbers that we would like to see. Then we have the lower transfusion trigger. I'm not sure if you're looking at this box. Can you see this box? Is it blocking your way?
No, we see everything clearly.
We see everything. So it's my monitor then that is blocking this mic. Anyway, so how do we do that? What's the science to guide us? Back in 85, there was not much of this. In the early 90s, there was not much of that. Then we go on to the usefulness of stored blood. And then we like to use, okay, blood draws is another thing, the benefit from it, and then physiology of hemoglobin, supply and utilization. This is really interesting because up until the early part of the 90s, I did not have anything to convince my surgeons that you do this, you operate on this patient. But what physiology are we talking about? Well, hemoglobin extraction threshold is actually something that has been established. And we know that it's myocardial central nervous system, approximately the concentration that it makes it really critical is 3 to 5 grams of hemoglobin that causes systemic lactic acidosis. So when we have that, we have some tool to tell the surgeon, you know what, this is what the literature says. And who said that? Well, the one who said that was Wilkerson. Wilkerson, looking at the status of anemia, I'm sure you have seen this. I'm just not very sure why this has not been used in a degree that very often, because this one convinced my surgeons to do this surgery so that they will be able to do this with a lot of confidence. So 3 to 5 grams of hemoglobin. So what do we know? Physiology then, as we know, raises concern at the hemoglobin of 4 to 5 grams. I don't know why not so many is using this logic to lower transfusion trigger. But what we know in this study, both in animals and that of humans, the relationship of supply and demand of oxygen. You look at this graph here, on the bottom is the DO2 or the delivery of oxygen, and in the vertical axis is the VO2 or the consumption of oxygen. What do we know from this? We know from this that at a certain point, about 200 ml/m squared per minute, we know that no matter how much you supply, the consumption is the same. It doesn't matter you have more than that, the consumption plateaus. So your consumption plateaus at that level. Now, what is that level? Remember, it's DO2, 200 above. That is 184 ml per meter square per minute. And what is that in terms of hemoglobin? That is a hemoglobin of actually 4 grams. So here we are, the study said it's critical at 4 to 5. Physiology says, yeah, it plateaus at 4. It doesn't matter if you have more, it doesn't really matter. You only need 4. So how do we correlate that now with the blood pressure? They will say blood pressure is low because hemoglobin is low, blood loss is massive. Now, take a look at this blood pressure cardiac output maze. It's a little bit complicated, it's a little bit plenty. But what I can show you here is the one that is in the preload. You will notice here in the preload, as the cardiac output, that to increase the cardiac output, you have preload increase and contractility increase. But preload is dependent on something else, volume constriction, and the other thing is fluid volume. It doesn't say blood. It's just fluid volume. In other words, fluid volume determines cardiac output. So there's no truth, therefore, that if you lose a lot of blood, you cannot replace it with fluid volume. Because that's just what you need, fluid volume. It does not have to be blood. So blood pressure requires volume, any material. Oxygen mechanics, we know, is distorted in blood. Restricted blood use is non-inferior or better. We have a lot of literatures coming out these days. And no blood, no complications. So that's what we know. I run to my surgeon, I tell them, you know what, this is what the literature says. You can operate really, you can go down to 4 and 5, it doesn't really matter. So my surgeon started operating at 7, at 6, and sometimes even at 5, electively. But eventually they were operating, as I will show you later on, with hemoglobins of less than 2. So both patient blood management and bloodless medicine surgery utilize multidisciplinary approaches using evidence-based medicine. However, bloodless medicine gives no room for blood utilization for the care of patients who might otherwise need blood transfusion or blood fractions based on current medical practice. So bloodless medicine and surgery, therefore, is tailored fit for Jehovah's Witnesses. The program that we have at East Avenue Medical Center back in the early 90s was really designed to address Jehovah's Witnesses for the simple reason that nobody was willing to operate on them. So they run to this center, and this center is really a government facility. It's mainly serving charity patients in the National Capital Region. It's 700-bed capacity. Its funding is coming from the Department of Health. All services provided except this transplant, which is done in a hospital about 500 yards away. or interventional cardiovascular procedures in a hospital about 100 yards away. So in this hospital, we're dealing with poor patients relatively. No universal insurance coverage was available during the entire program of the duration. There was a limited field health insurance, which was available for some. Laboratory procedures were shouldered by the patient. Most of the medicines were purchased by the patients. Board and lodging were free. Intensive care facility was fully equipped, but not sufficiently supplied with consumables. The services of the medical personnel were free. And just to relate to you the income of these people, it's not that it represents the whole country, but this is the group of patients that we are talking about for this particular care in this particular hospital. Back in 2015, the GDP of the Philippines was 306 billion. If you look at 2015 per capita in the Philippines, it was 2,867. We computed that, and basically for a family of 6, that is $50 per month per member of the family. $50 per month. Nigeria is 2,176 back in 2015, and the US was 52,000. Look at 2020. The Philippines has contracted from 376, now it's 367 billion. And that is true to all economies in the world today. And the per capita, the Philippines is 3,000, Nigeria is 2,250, but still at 3,000, it's just a little over $50 per month for each member of the family. That's really something that is difficult for this group of patients. So the Bloodless Medicine program at East Avenue consisted of a director. I was acting as one, nurse secretary, and we have cooperative physicians in almost all specialties: general surgery, thoracic and cardiovascular surgery, orthopedic surgery, colorectal surgery, down the line. None of these surgeons and anesthetists are Jehovah's Witnesses. They are all general practitioners. They are all diplomates in their field. Now, let me tell you a few of these cases. Case number 1, 20-year-old male, gunshot wound, consulted 2 months after the gunshot wound in an island. He was transferred to another hospital and finally admitted to East Avenue. The hemoglobin on admission was 1.9. You might think, that's not true. That's not true. This is a hemoglobin determined 3 times. They wanted to do a 4th time. I didn't allow it anymore. Extracting blood, nobody believed it was 1.9. So let's just show you the map of the Philippines, where this patient came from. It came from Panay, go to Palawan, which is now close to the conflicted West Philippine Sea. And from there, went to Manila. That's where we found him with a hemoglobin of 1 point something. And what did we find? He arrived in the morning. He went to surgery that afternoon. Femoral artery transection, pseudoaneurysm. Procedure, suture ligation, excision of pseudoaneurysm. Uneventful surgery on admission. Hemoglobin 16 days post-op was 6. Patient was discharged 21 days after. Not because of the hemoglobin, but because of the infection that was going on. Case number 2. This one is very common, I'm sure. A lot of you can do this. Uterine myoma with aplastic anemia. It's a different combination. Consulted 12 months after initial diagnosis, again in one city in the south. Transferred to another facility in another city, then to another city, and then finally to East Avenue. Let me just show you the sojourn of this patient. The hemoglobin on admission was 3.9. Can you imagine the stress of this patient having this kind of problem? No wonder when she arrived, the hemoglobin was really low. Of course, the patient was operated when hemoglobin was 4.4. The procedure was just hysteroscopic myomectomy, which we all know is now very easily done. Back then in 1995, this was not that so. No blood, no plasma, no RPO, no cell saver, uneventful surgery. Another one, Caucasian, this one is from Guam. He was in the medical gynecologist, both in Guam and in Manila. He was not, again, operated. The hemoglobin on admission was 9.3. Again, let me show you. She's from Guam, went to the Philippines, nobody operates, goes back to Guam, goes back again to the Philippines, knowing that we're doing it at East Avenue. Finally, she got the surgery and went home happy. Another one is TABSU, no blood, no plasma, uneventful surgery, discharged 5 days. Oh, this same patient. Another one is dengue fever. Admitted on the 3rd day of fever, the platelet was 16. Nothing was done, just IV fluids and antipyretics, discharged after 5 days. Another case, 17-year-old male, Petrology fellow, admitted to the next hospital, 100 yards away. The pre-op hemoglobin was 11. Procedure was total correction of defect, aortic valve replacement, no cell saver, no ANH, no APO. He's now a fully functional adult with full children, 20 years post-op. Another one, coronary artery disease with diabetes and dyslipidemia, admitted to another hospital, but under the oversight of the bloodless program personnel. No blood, no plasma, pre-op 12, post-op 7 hemoglobin, is currently in functional class 1. So what do we observe from these patients? There are a good number of them. Observations from all patients seeking non-blood management in these hospitals, East Avenue, St. Luke's, and Philippine Heart Center. Well, these are patients that are seeking from all over the place. They're sicker than the average patients, simply because they've been shuttling from one island to the other, one hospital to the other, from all over the Philippines. Majority are Jehovah's Witnesses. Total number of cases over the 19 years period was 1,925, distributed in these groups. What are the cases here? Abdominal perineal resections, Hartmann procedures, traumatic injuries, gunshot wounds, craniotomy with cerebral hemorrhage, small and large bowel surgeries, large tumor excisions, coronary artery bypass graft, anemia, malignancies, dengue hemorrhagic fever, chronic kidney disease, and hemodialysis, GIB, leukemias. I think this is the run of the usual things that comes to a general hospital. Abruptio placenta, cesarean sections, gynecologic malignancies, placenta previa. So this is what we see. You'll notice here that the bloodless program utilization over a 19-year period was tabulated per year. And it's not always that we get a lot of these patients, because in this hospital, only those deemed needing a referral to a bloodless program was enrolled in this program. If you're going to look at the mortality of the hospital in the last 10 years of this program, the mortality in the hospital is 6%. It's a bit high. By any standard, it is high. But this is a hospital that caters to the lowest income group in the country, who's got no money and was probably very sick when they get to the hospital. But for the program mortality, it was only 5.2%. I don't think that is significant, but it does tell you that it is not inferior in the way that it is compared to the hospital mortality. What is interesting is that the use of erythropoietin is just 14%. Cell saver, we had a cell saver, we had a harmonic scalpel, we had all the medications. Use of cell saver is only 0.31%. Jehovah's Witnesses, 73%. Mortality is 5.2%. Mortality in East Avenue in the last 10 years was 6%, as mentioned. So what do we observe from this study, from this observation? This is not a study, this is just a report of cases that we have. Typically from multiple institutions, no special tools, techniques, or pharmacology. Physician providers, they are just ordinary cooperative physicians who are cooperative with the patient's visits for no blood. Diplomates and their specialty utilize standard surgical technique. There was nothing unusual. There's no harmonic scalpel. There's nothing of the sort that you would be talking about here. We've been talking for the last 4 days. These are just standard surgical techniques. Well, the basic considerations of the program address medical issues without delay, deliver medical care without religious bias, and be guided with available medical knowledge. What was the knowledge? The knowledge was simply, you can operate patients with a hemoglobin of 4 or 5. And then do the rest, use your best to limit the loss of blood. The hospital now has become a referral center for bloodless medicine and surgery, and those physicians who finish training continue to be cooperative in treating Jehovah's Witnesses in other centers. However, the bloodless medicine and surgery remains a standard care for Jehovah's Witnesses only coming to the center. If you're not a witness, you won't get that kind of treatment or bloodless medicine approach. The cooperative physicians that we have in the program continue to give blood to non-Jehovah's Witness patients. So it's not like they're really convinced 100%, or maybe they are, but they are afraid of the legal implications that may arise by not using or giving blood. Thank you very much for your attention.